Hello everyone. I'm Dr. Murtaza, mentor at StudyMEDIC. Today we'll be discussing a very important topic, which is like congenital heart disease. In our last video, we have discussed about congenital heart disease. So we'll be taking it further into acyanotic congenital heart disease. And in this case, we will be first seeing like what are the acyanotic congenital heart diseases, how do we classify them, what are the different lesions which are coming under this acyanotic congenital heart disease, and then we will be doing on the different types of murmurs, what are innocent murmurs, how to differentiate the different types of murmurs in this case, and we'll be moving around with a few questions in this series after that. So for the suspicion of congenital heart disease, so we have something known as NADA's criteria. So in the case of NADA's criteria, the important thing is that it is a screening test, and it is used when we suspect a child to be having a congenital heart disease. So to fulfill this NADA's criteria, we should have either one major or two minor criterias to fulfill it. So for the major criteria, we have four things. For the minor criteria, we have five things. For the major criteria, the things to like aid to remember in this case is these are major things. It can have congestive heart failure. It can be cyanotic. A murmur, systolic murmur, which is loud, grade 3, 4, 5, and 6, or any diastolic murmur. So this comes under the major criteria. Whereas for the minor criteria, it can be remembered with a mnemonic. Like one thing is from the general physical examination of abnormal BP. There are two things which you get in the auscultatory criteria of abnormal second heart sound or a systolic murmur which is fainter, grade 1 or grade 2. And if you go on to move on to do the test, then you will get the abnormal chest X-ray or the abnormal ECG. So for the suspicion of congenital heart disease, you have a screening test which was given by NADA's as NADA's criteria. To fulfill it, you have one major or two minor. For the major criteria, gross things are there in the form of congestive heart failure, cyanosis, louder systolic murmur, and a diastolic murmur. Whereas in the minor criteria, you have abnormality in the BP. When you auscultate, you will get an abnormal second heart sound or a fainter systolic murmur of grade 1 and 2. And when you subject the child to the test, you are getting abnormality in the chest X-ray or the ECG. So NADA's is a screening test, one major, two minor. That's what is to be needed in the case of NADA's criteria. The second thing is to be confirmed, seen in this case is like you have suspected the child to be a case of congenital heart disease. So then you will have to see that is the child looking cyanotic to you or not. So basically what we have to emphasize in this thing is cyanosis by definition, it's a clinical thing. So cyanosis is bluish discoloration of the skin and the mucous membrane. If it is a clinical thing, we do not use any instrument to detect it, right? So cyanosis can be detected by our eyes. So we are calling it as a bluish discoloration of the skin and the mucous membrane. So our eyes will have certain limitation to pick up the cyanosis. So only when the saturation is less than equal to 85%, then only our eyes can pick up this saturation. Whereas if the saturation is above 85%, our eyes cannot see that there is something abnormal. But we know that the normal saturation is more than equal to 94%. So any saturation which is 94, 95, 96, 97, 98, 99, 100 is normal. Anything below 94 is abnormal. So between 85 to 93, we have something known as, although it falls in the basket of cyanotic heart disease, but actually our eyes are not able to see it. So we call it as congenital heart diseases with arterial desaturation. And this will be put in the basket of cyanotic congenital heart diseases only. So anything which is less than 94% will come into the basket of congenital cyanotic heart disease only. But the question here is that eyes can pick up only when the saturation is less than equal to 85%. For all practical purposes, if you are suspecting a congenital heart disease, the saturation, if it is more than equal to 94%, it will go into the basket of acyanotic congenital heart diseases. Whereas if the saturation is less than 94%, 93 and below, it will be in the basket of cyanotic CHT. This is what is to be understood in this slide. Another important concept which is to be understood is the hyperoxia test. So this is a very common test which was used in the past, but now it has become obsolete. But for examination purposes, we should be aware of what this hyperoxia test is. For this hyperoxia test, basically it is again a screening test, and it is basically used to see if the cyanosis in a neonate, it is done in a neonate, is due to the cardiac cause or respiratory cause. So a neonate is there with us, and the neonate is cyanotic, and we want to see if this cyanosis is really due to the cardiac cause or the respiratory cause. The second important thing in this hyperoxia test is it is not done with a pulse oximeter. It is an invasive test, and you have to do the ABG because we use PO2s in this case and not SPO2. So you have to do 2 times ABG. You have to prick the neonate, small neonate 2 times in this case to get the hyperoxia test. So you want to get the ABG so that you can see the PO2. How do we do it? So how do we do it? You will do first the ABG of the cyanotic child, cyanotic neonate and room air. See the PO2s in that, give 100% oxygen for 10 minutes. Then you will again prick the child, do a ABG, get a PO2s and see the value of this PO2. If this PO2 is more than equal to 150, 50 mm of Hg, you can attribute the child, the cause of cyanosis in this child to be respiratory. But whereas if it doesn't increase beyond 150, the cause of cyanosis in this case is cardiac cause. So this way it differentiates into the cause of cyanosis is as either respiratory when the saturation is rising more than 150 mm of Hg, whereas if it doesn't rise beyond 150, it is called as cardiac cause. So why do you want to prick the child in this case and make it invasive? It is very important to understand the concept. So we all know that in a neonate, the hemoglobin which is in a neonate is different. It is not the adult hemoglobin. It is known as fetal hemoglobin. And the peculiarity of this fetal hemoglobin is that it has more affinity for the oxygen. So it binds the oxygen very tightly. So if it binds the oxygen very tightly, it will not let the oxygen go easily. So it shifts the oxyhemoglobin dissociation curve, which we can see on the left of our screen, into the left side. So the normal oxyhemoglobin is the right curve. So this fetal hemoglobin is pulling it towards the left side. So this oxyhemoglobin curve is shifting to the left. Now see if at a same partial pressure of oxygen, like if it is at 30, the adult hemoglobin is showing the saturation around 50, SpO2 around 50, whereas at the same partial pressure of 30, the fetal hemoglobin is showing a higher SpO2 of around 70% in this graph. So this shows that the fetal hemoglobin, since it has more of oxygen affinity, it is showing a higher SpO2. So that is why in the case of hyperoxia test, we do not use the SpO2 and we use the PO2s in those cases. So the important things to be remembered in hyperoxia test is it's a screening test. It's done in the neonate. You have to prick the child 2 times. ABG is used in this case. PO2s are used in this case, not SpO2. You measure the PO2 at room air, give 100% oxygen 10 minutes. Again, take the ABG and measure it again. If the saturation is, if the PO2 is more than 150, the cause goes more towards respiratory causes of cyanosis. Whereas if the saturation is not rising to more than 150, it is below 150, the cause is attributing to cardiac causes of cyanosis. So this is what we have to remember in the case of hyperoxia test. Moving on to the classification of acyanotic congenital heart disease. So any congenital heart disease in which the saturation is more than equal to 94% and above, we call them as acyanotic congenital heart diseases. So the acyanotic congenital heart diseases are universally classified as either shunt lesions, obstructive lesions, or the regurgitant lesions. So anyone can classify the acyanotic congenital heart diseases as shunt, obstructive, or the regurgitant lesions. For the shunt lesions, we have classified them into those which are above the tricuspid wall and those which are below the tricuspid wall. Why have we classified them as above the tricuspid and below the tricuspid? Because it is solely hemodynamic based. Those shunt lesions which are above the tricuspid wall, they cause the right heart dilatation. RA and RV will be dilated along with the pulmonary artery. Whereas those which are below the tricuspid wall, in which left heart is dilated, LA and LV is dilated along with the pulmonary artery. So pre-tricuspid shunts will cause the right heart dilatation, whereas the post-tricuspid shunts will cause the left heart dilatation. This is a very important differential between the two, and it is repeatedly asked in the exams. So what are the examples of the pre-tricuspid shunts? Those which are above the tricuspid wall. They can be either ASD, a partial anomalous pulmonary venous communication. What is partial anomalous pulmonary venous communication? There are four pulmonary veins, they drain into LA. If one, two, or three of these pulmonary veins are erroneously draining into the RA, either directly or indirectly, it becomes a PAPVC. If all the four drain into the RA, then it becomes a TAPVC, which is cyanotic. We will be not talking about it. So if one, two, or three only will drain into the RA erroneously, it is known as PAPVC, and this becomes a pre-tricuspid shunt. Or anything which is opening into the RA, like a coronary cameral fistula, which is opening into the RA, will be acting as a pre-tricuspid shunt. So the classical examples of ASD, any type of ASD, whether it be secundum ASD, a primum ASD, a SVC type of ASD, a coronary sinus type of ASD, or a IVC type of ASD, all the ASDs will be a pre-tricuspid shunt. Any PAPVC is a tricuspid shunt. Anything opening into the RA, the coronary cameral fistula, will be a pre-tricuspid shunt. Move on to the other subcategory of post-tricuspid shunt. Why are post-tricuspid shunt different from the pre-tricuspid shunt? Because the post-tricuspid shunts causes the left heart dilatation. So the examples of post-tricuspid shunt will be the most common congenital heart disease, VSD, the PDAs, the AP window, the AV canal defect with large inlet VSDs, anything which is opening into the RV or the PA, like coronary cameral fistula, which is opening into the RV or the PA, will lead to the post-tricuspid shunt. So the examples again are VSD, PDA, AP window, AV canal defects, coronary cameral fistula opening into the RV or the PA. So these are the shunt lesions, the pre and the post and the examples of it. Moving on to the second category of obstructive lesions and the third category of regurgitant lesions. Remembering the lesions in the obstructive and regurgitant is very easy. We have four walls in our body: aortic valve, pulmonary valve, mitral valve, tricuspid valve. For the obstructive lesions, you make them stenotic. For the regurgitant lesions, you make them regurgitant or leaky. So the examples of obstructive lesions are aortic valve, aortic stenosis; pulmonary valve, pulmonary stenosis; mitral valve, mitral stenosis; tricuspid valve, tricuspid stenosis, along with stenosis in the aorta, which is coarctation of aorta. So these are the five examples of obstructive lesions: AS, PS, MS, TS, and coarctation of aorta. Moving on to the regurgitant lesions, there are four valves again, and they can leak. So aortic valve can lead to AR, pulmonary valve can lead to PR, tricuspid valve can lead to TR, mitral valve can lead to MR. So AR, PR, MR, TR. So these are the regurgitant lesions. So again, the acyanotic congenital heart diseases as shunt lesions into pre-tricuspid, post-tricuspid, pre-tricuspid causing right heart dilatation, post-tricuspid causing left heart dilatation. Examples of pre-tricuspid: ASD, PAPVC, coronary cameral fistula into RA. Examples of post-tricuspid: VSDs, PDAs, AP window, AV canal defect, coronary cameral fistula opening into the RV or the PA. Examples of obstructive and regurgitant: all the four valves can get stenotic or regurgitant, add coarctation of aorta in the obstructive basket. So this is the way whole of the acyanotic congenital heart diseases are classified. So this slide is very important for all of us, and questions are repeatedly asked. So these cases will not have their saturation abnormal. They will always will have their saturation more than equal to 94%, which is in the normal range. So remember these lesions. If you have questions with these lesions, the child won't be cyanotic. They will be acyanotic. The saturation will be normal in these cases. So these are the presentation of the sum of the common congenital heart diseases of left to right shunts. So like the atrial septal defect. So normally the atrial septal defect, they do not produce the murmur due to the shunt because due to the flow, excess flow, they can have some ejection systolic murmur due to the excess flow across the pulmonary valve area. So they can have a soft ejection systolic murmur in the pulmonary region, which is the left upper sternal border. So in the ECG, what do you get? You get partial right bundle branch block in the V1, RSR- passion. We all know that. And X-ray scan showed cardiomegaly. So how do we manage them? Normally, we do device closure, percutaneous device closure of these ASDs after 3 years of age. And in rare situations, we have to do surgical closure also. So most of them are done by device closure. Now the second, this is the most common type, which was the secundum type. Second most common type of ASD is the primum ASD, or the which is also known as the partial AV canal defect. This will also have like ejection systolic murmur if it is large at the pulmonary area. And if it is a partial AV canal defect and there is some small VSD, it can produce a apical pansystolic murmur due to the VSD. ECG in this case is very important because you will get the superior axis in this case, left axis or the superior axis, and the X-ray will show as cardiomegaly. So ECG is guiding in these cases. So how do we manage the primum ASDs? Normally, primum ASDs cannot be closed with device closure. So we do them open heart surgery for these because they are also associated with leakage of the mitral valve, which is the cause of the pansystolic murmur, not the VSD. I'm sorry. So the mitral valve leakage, left AV valve regurgitates, and we have to do the closure of the mitral valve also. Moving on to the ventricular septal defect, we all know that the LV is at pressure of 120 by maybe 10 and the RV is a pressure of 25 by maybe 10. So throughout systole, there is a pressure difference of 120 minus 25. So there is a pansystolic murmur at the lower left sternal border. And normally, how do we manage the small VSDs? They will close spontaneously. Whereas if the defect is large, you will do surgical closure of these defects when the child is around 3 months to 6 months of age. And if it is moderate in size, we can do device closure of this child in the cath lab. In the case of a patent ductus arteriosus or a PDA, they will have a continuous murmur. Why do they produce a continuous murmur? The pressure in the aorta is 120 by 80. The pressure in the PA is 25 by 10. So in systole, there is a pressure difference of 120 minus 25. In diastole, there is a pressure difference of 80 minus 10. So throughout the cardiac cycle, both in systole and diastole, there is a pressure difference of pressure difference between the two great vessels. So you get a continuous or a machinery murmur. And normally we do device closure of these PDAs. Rarely there is PDA ligation surgically also done, but in most of the cases we do percutaneous device closure of these PDAs. So this is a question which is there, like there's a 3-year-old child which is healthy and incidentally diagnosed to have a soft cardiac murmur and there is no past history of significance. Cardiological examination was done by a cardiologist. Everything is normal. What is the cause of murmur? So this is a cause of innocent murmurs. There are some murmurs which are innocent and they are characteristic. So these murmurs normally they will be like very short duration. They are mostly systolic, never diastolic. They will not be associated with any clicks or gallops. They are smaller, soft amplitude. They are not normally harsh. They are sweet, occurs in systole, and they are normally sensitive. It changes with the position of the child. So these are known as innocent murmurs. The different examples of innocent murmurs are like still murmur, pulmonary flow murmur, the venous hum, which is a continuous innocent murmur, the peripheral pulmonary stenosis, or the supraclavicular or the carotid buoy. So innocent murmurs are innocent. There is no pathology associated. They are never loud. They are mostly in systole, except the venous hum, which is a continuous. They are never in diastole. They are never loud. They are never harsh. They changes with posture. So these are some of the things which are characteristic of the innocent murmur, and we all should be aware of this. So for the murmurs, what I want you all to be very much sure of is like I'll tell the murmurs in a simple fashion so that you can apply it in it. For the systolic murmur, you have to remember all the murmur we have to classify as either systolic, diastolic, or continuous, first part. Then we will move on to the systolic murmur. There are only two things which are systolic murmur, which are systolic, either a pansystolic murmur or a ejection systolic murmur. So All the pansystolic murmur are found below the nipple. We have only three causes of pansystolic murmur in the world, which is a VSD, a mitral regurgitation, and a tricuspid regurgitation. All the three are below the nipple. The pansystolic murmur of VSD is at the lower left sternal border. It is at the apex for mitral regurgitation. It is at the right sternal border in the tricuspid regurgitation. Only three causes of pansystolic murmur in the world: VSD, MR, and TR. The other type of systolic murmur is above the nipple, which is known as ejection systolic murmur. There are two ejection valves in our body which eject the blood out of the heart. These are the aortic and the pulmonary. So it can be aortic stenosis and pulmonary stenosis. Though there are only two causes of ejection systolic murmur in the world, which are aortic stenosis and pulmonary stenosis. Aortic stenosis, the murmur will be in the right side upper sternal border, whereas it will be on the left side upper sternal border in the case of pulmonary stenosis. That's it, what you have to know about the systolic murmur. So systolic murmurs which are below the nipple are always pansystolic murmur, VSDs, MRs, and TRs. Systolic murmurs which are above the nipple are always ejection systolic murmurs. Only two causes, AS and PS. That's it. Close the chapter. Come on to the diastolic murmurs. Again, in the case of diastolic murmur, we'll go below the nipple and above the nipple. So below the nipple, you have two valves to cause the diastolic murmur. So the diastolic murmur which are below the nipple are produced due to the either mitral stenosis or a tricuspid stenosis. If it is at the apex, it is a mitral stenosis murmur, whereas if it is at the right sternal border, it is a tricuspid regurgitation, tricuspid stenosis murmur. So the murmur, the diastolic murmur, which is in this is known as mid-diastolic murmur. So mitral stenosis produces a mid-diastolic murmur below the nipple at the apex. Tricuspid stenosis produces a mid-diastolic murmur below the apex in the right lower sternal border. That's it. Move on to the diastolic murmur which are above the nipple. The diastolic murmurs which are above the nipple are due to the two ejection valves again. So it will be either a pulmonary regurgitation or a aortic regurgitation. So finish the chapter of diastolic murmurs. They are below the murmur which are mitral, mid-diastolic murmur of mitral stenosis or a mid-diastolic murmur of the tricuspid stenosis. If it is above the nipple, it is either a pulmonary regurgitation murmur or a aortic regurgitation murmur. That's it. Close the chapter of diastolic. Move on to the third type of murmur, which is known as the continuous murmur. The most common example of continuous murmur is a PDA. So a PDA, a AP window, there is a continuous flow between the aorta and the PA because the pressure difference between the two is maintained throughout the cardiac cycle. So a PDA, AP window, collateral, BT shunt, these are the causes of continuous murmurs. So systolic murmurs, diastolic murmurs, continuous murmurs. Systolic murmurs below the nipple only and only pansystolic murmurs, MR, TR, and VSD. Systolic murmurs above the nipple are only ejection systolic murmurs, AS and PS. That's it. Come to the diastolic murmurs. Below the nipple is mid-diastolic murmur of MR and the mid-diastolic murmur of TR. Above the nipple is the pulmonary regurgitation and the aortic regurgitation. Coming to the continuous murmur, it is produced due to the PDA, a AP window, a BT shunt, or a collateral. This is the whole chapter of murmurs. Hope that the things are clearer to you all. We'll go through a few questions now and then we'll finish off this session. So this is a 2-year-old child with a moderate VSD and is being followed up. What complication may develop if the defect remains untreated? So if the child is having a moderate to large VSD, it should be including a large VSD. So normally the large VSDs and less likely the moderate VSDs. If it is left untreated, this will lead to increase in the pulmonary arterial pressure, which can eventually lead to Eisenmengerization. So shunt lesion left untreated, large shunt lesions can Eisenmengerize. So the thing should be a large VSD, less likely a moderate VSD will go into the Eisenmengers. So Eisenmengers is increase in the pressure. Pressure is flow into resistance. So initially the pressure of the lungs was high due to the increase in flow, excess flow was going. So after some time, the lung vasculature becomes stiff. So if the lungs vasculature becomes stiff, the R component of the pressure increases, the resistance increases. So if the resistance increases, then the flow will not increase, but the pressure will increase. So the first part, it was a hyperkinetic pH, whereas in the second part, it was an obstructive pH. The obstructive pH is what is known as the Eisenmenger syndrome. So any large shunt lesions, if they are left untreated, it will lead to Eisenmenger syndrome. So the answer of this question is Eisenmenger's. Move on to this question. So, which congenital heart disease is mostly associated with maternal rubella syndrome? So, maternal rubella syndrome normally is associated with a triad of congenital deaf mutism, congenital cataract, and congenital heart disease. And the most common congenital heart disease is a PDA and a peripheral PS. So we have the option of PDA in this case. So answer in this case is PDA. And even if there is PS given in this case, we can mark that also. So maternal rubella syndrome, we should be aware of the maternal diseases or the maternal medicines which will be causing the congenital heart disease. So maternal rubella, first option PDA. If there is PS, you can mark PS also. Mostly peripheral PS. Moving into the third question, a newborn develops shock at 5 days of life with weak femoral pulses and metabolic acidosis. What congenital lesion should be suspected? So a newborn who is developing shock around 5 days of life. So, and there is metabolic acidosis and you are not getting femoral pulses. So most likely the systemic circulation is compromised. So systemic circulation can be compromised in the case of coarctation of aorta. There is obstruction to the systemic flow of the blood. The blood is not going to the lower part of the body. So the child is presenting shock. Why is he presenting at day 5 and not earlier? Coarctation is from birth. Why is he delaying? Because there was PDA. This is a duct dependent systemic lesion. There was a PDA in this case before day 5. So the PDA normally closes around day 3, day 4, day 5. So once the PDA closes, the child present with shock. So if it is a duct dependent lesion, you should ideally, if you have diagnosed in these cases, you should ideally start prostin and then refer the child to a pediatric cardiologist for further management. So this is the case of coarctation of aorta. Start prostin in this case. That's important. That is another question which is normally asked in these scenarios. The next question is, a continuous murmur is heard in a 1-year-old child with bounding pulses and a wide pulse pressure. What pathophysiological mechanism explains this? So basically, this is a case of continuous murmur. Okay, so when is a continuous murmur produced? There is a significant pressure difference throughout the cardiac cycle, which includes both the systole and the diastole. So there is a pressure difference in systole and diastole. Think aorta. Aorta is a pressure of 120 by 80. Pulmonary artery is at a pressure of 25 by 10. So in systole, there is a pressure difference of 120 minus 25. Whereas in the case of diastole, there is a pressure difference of 80 minus 10. So throughout the cardiac cycle, there is a pressure difference between the aorta and the PA. So this produces a continuous murmur. So if you see the second option, the left to right shunt lesion between the aorta and the pulmonary artery is the answer in this case. So, and you are getting a bounding pulse because there is aortic runoff. The blood is being stolen from the aorta during the systole and the diastole. This is called as runoff and this produces a wide pulse pressure. The wideness of the pulse pressure is due to decrease in the diastolic pressure and not an increase in the systolic. So the pulse pressure is wide because the diastolic pressure is low. So this gives a right pulse pressure and the pulses are bounding in this case. Moving on to the next and the last question of this spectrum. Which of the following auscultatory findings is most characteristic of atrial septal defect? So for the atrial septal defect, the most characteristic finding is a wide and a fixed splitting of the second heart sound. This is a characteristic finding of the atrial septal defect. So if there is, the question mentions that on auscultation, the second heart sound is found to be wide and fixed splitting, you have to invariably mark atrial septal defect. This is a subtle sign which is to be seen. ASDs normally do not produce any murmur except when they are large and it produces a flow murmur across the pulmonary wall, which will be ejection systolic murmur, or across the tricuspid wall, which will be a mid diastolic rumble. ASD shunt does not produce any murmur. What it produces is a fixed and wide splitting of the second heart sound. So to summarize the things in this case of acyanotic congenital heart diseases, so these acyanotic congenital heart diseases are suspected based on the NADA's criteria. After you have suspected, you will be classifying these acyanotic congenital heart diseases into shunt lesions, obstructive and the regurgitant lesions. Shunt lesions are further classified as a pre-tricuspid and a post-tricuspid. The pre-tricuspid shunt will have a right heart dilatation, whereas the post-tricuspid shunt will have a left heart dilatation, whereas the obstructive will have a obstruction, stenosis, and a regurgitant will have a regurgitant leakage of the wall. Moving on to the different murmurs, we have seen how to classify them and what are the different examples, descending them into systolic, diastolic, or the continuous, above the nipple and below the nipple. Moving on to the innocent murmurs, we know that they are soft, never loud. They are always systolic, except one venosum, which is continuous. They are never loud, never harsh. They will be like changing with posture. These are some of the characteristics of the innocent murmurs. And this is the way it goes. So this way, the classification of acyanotic heart diseases is to be done, and we should be aware of the common lesions, the shunt lesions like VSDs, PDAs, ASDs, the obstructive like AS and PS, and the regurgitant like AR or PR. Hope the things are clearer to you. Thank you.